This is a precision analytical case study. This is for Dr. J.S. for patient initials RB. We're looking here at a male patient in his early 60s. And so we're just going to kind of go through the report here. So I think there's some interesting observations. Feel free to watch our other educational videos that we've posted if you want to dig in deeper to any particular topic, generally speaking. But this is one particular case study that I think is of interest. So page 1 of the report, of course, lists the hormones. We're going to hop straight to page 2, and we're going to look at some of these sections in greater detail. Nothing too noteworthy about progesterone or its metabolism. What we really want to look at are the androgens and the estrogens here, and then we'll look at the adrenals as well at the end. So if we zone in on the androgens, what we can see with this particular patient, and this is again a gentleman in early 60s, so testosterone levels are on the higher side of normal, which is fairly impressive given the patient's age. And DHEAS levels are a little bit low, which I think we'll see when we hit into the adrenals, being that DHEAS is both an androgen and an adrenal hormone, that this may have to do more with adrenal insufficiency. But what we want to look at real carefully is for this particular patient, it seems that we've got a lot of DHT. Now keep in mind, DHT is 3 times more potent than testosterone, and has been implicated at some level with prostate cancer risk. So we want to look at that a little bit. What I want to point out on this patient for his androgens is just how extreme the 5-alpha reductase is. So the reason that 5-alpha reductase is relevant is you have testosterone. So these are 3 separate hormones: androstenedione, testosterone, and cortisol. Now cortisol doesn't have anything to do with androgens per se, but all 3 of these hormones are metabolized by 5-alpha reductase, 5-beta reductase. So androstenedione by 5-alpha goes to the more androgenic androsterone, and to etiochalanolone by the 5-beta reductase enzyme, and that's not androgenic. Same thing with testosterone. It goes to 5-alpha DHT, which is the most androgenic hormone, and then 5-beta DHT. Those are competing pathways, and 5-beta DHT is not androgenic at all. So with cortisol, same thing. The 5-alpha and the 5-beta. Now the end products of cortisol, again, are not relevant for discussing androgens, except to say, look at each of these. 5-alpha metabolite of cortisol is alpha THF. It's high. The beta metabolite, beta THF, is on the lower side of normal. So there's a big preference for alpha. So look at the testosterone metabolites, and you can see, again, on the higher side, on the lower side. With androsterone, again, same thing, on the higher side, on the lower side. So what we get in aggregate, and that's what we can see on the bottom here, is an aggregate score of that. And so we've got a huge preference for 5-alpha reductase. Now, there are issues of what that means, and then there are issues of what causes that. Some of what causes that is probably going to be genetic. Insulin resistance is an example of something that upregulates 5-alpha reductase, but the main effect of that we really want to focus on is that 5-alpha reductase, again, of testosterone is going to make lots of DHT, and that's going to influence our risk profile for prostate cancer. Now, what you do about that is a fairly complicated topic, because you can give drugs like finasteride, which will essentially stop that 5-alpha reductase, and so now your 5-alpha DHT is going to go down, and with it, your risk of prostate cancer, which sounds just terrific, but the problem is there are other metabolites down this pathway. So from DHT, you get 5-alpha. So this androstenediol is 5-alpha, 3-alpha androstenediol, and there is also a 5-alpha 3-beta androstenediol that's right next door to it, and that has some positive effects for prostate cancer. So you are less likely to get prostate cancer if you are on finasteride. But if you get prostate cancer, you are more likely to die because you're more likely to get a high-grade prostate cancer. So it's not an easy topic in terms of what you should do. A gentler way to sort of shunt some of that testosterone back down the beta pathway is to take something like saw palmetto. Again, that's going to reduce all of those 5-alpha metabolites. And so we can see here with this particular patient that if he's got, and I don't know, but if he has some issues in terms of enlarged prostate, things of that sort, then this is something that is very relevant. If you saw these types of patterns with a female, then you would want to ask whether they had symptoms of high androgen. So the issue with women is not as much a risk for something as it is just symptoms of high androgens being, excess facial body hair, acne, oily skin, things of that sort. People with PCOS, for example, have up-regulated 5-alpha reductase, which means what? They make more DHT, so they're getting more androgenic punch, if you will, out of their testosterone, and that's likely what you're going to see with this gentleman as well. So you obviously want to take the whole clinical picture into account, but this is an interesting pattern for this particular person. Moving on, we want to look at estrogen levels as well. So estrogens come from testosterone, and we can see your primary estrogens are E1, E2, and E3, but E2 is the most potent. And so you can see for this particular patient, he's not making a ton of estrogen, or at least estradiol, out of his testosterone. Now, estriol is a weaker estrogen, and for whatever reason, he's making a lot of that estrogen. So you can see here the 16-hydroxy-E1 is also elevated, and this actually makes a lot of sense clinically. Not to get into too much nerdy detail about the biochemistry, but estriol is 16-OH-E2. So when estradiol is hydroxylated at the 16 position, you get estriol. When estrone is hydroxylated at that same position, you get estrone. So this would be more relevant if it were a female patient, but still potentially somewhat relevant for a male. But you can just see that for whatever reason, this person genetically really favors that 16-hydroxy pathway. Now, estriol has some favorable characteristics, so favoring that's not that big of a deal. 16-hydroxy-E1 is a pretty potent estrogen. Has some unique properties that are not really favorable. So that's something to consider, especially with a female, but even so with a male a little bit as well. And so what we can see here is we can compare these three pathways. So your primary estrogens, both E1 and E2, have these three pathways. The 16-hydroxy, which again makes this somewhat potent estrogen. The 4-hydroxy-E1, and this is the one you really want to watch out for in women in particular, but also with men. This can influence, again, as we saw also with the DHT issue, it can influence risks of prostate cancer in that this 4-hydroxy-E1 can actually attach to DNA and create DNA damage, and those DNA complexes with the 4-hydroxyestrone have been linked to some degree to prostate cancer risk. And so what we would rather make, rather than those two metabolites, would be to favor this protective pathway to make 2-hydroxyestrogens. So when we're looking at this particular patient, you can see what's normal for a male, so this is normal metabolism, is about 74% 2, 11% 4, and 16% 16-hydroxyestrogens. And what this particular gentleman makes is 62% 2-hydroxy. So if you look at those two numbers, he's making a little bit less of that favorable metabolite than you'd like to see, and he's making a whole lot more of the 16-hydroxy estrogen. So, this might be a gentleman that you might, if you're really worried about prostate cancer risk, you might consider something like DIM, diindolylmethane, which would increase the metabolism of the protective pathway, and so that's something to consider. The last step in estrogen metabolism is methylation, where you take these hydroxyestrogens, some of which are good and some of which are bad, and you methylate them to make them more inert and protective. And so we want to look at that pathway, and that's the methylation activity. And you can see for this particular gentleman, he's got a normal 2-hydroxyestrogen and really high levels of the methoxy. So his relative methylation rates are very high. So he's methylating the hormones well. That means if he makes this 4-hydroxyestrogen, which is again bad, he should be methylating that fairly effectively. So that's a good thing. So if we move on to the adrenals for this particular patient, I like to start with, so the top part of this is just a tutorial. You know, you've got your brain, you get stressed, you're going to make CRH, and then in your pituitary you're going to make ACTH, which is going to stimulate your adrenal glands to make cortisol and DHEA, as well as a couple other hormones. And then we can look at some of those patterns, but I like to start with the daily free cortisol pattern. So for this particular person, it's a pretty clear message, and that is there's not much going on there. The HPA axis is blunted in terms of its response to making cortisol. So you can see, you know, the reference range is up in here, and this patient's pretty deficient for cortisol. So those 4 points in aggregate, all the cortisol made throughout the day, is then represented by this cortisol here. So you can see, as you would expect, if you're low at every point, then the total cortisol for the day is going to be really low, and so is DHEAS. So all of those adrenal hormones seem to be pretty low in terms of what's available to the body as far as cortisol goes. Now, if we look down a little bit further at cortisol metabolites, and notice how much bigger these numbers are, right? 5,000 versus 4. So most of the cortisol that you make finds its way by way of metabolism down to the cortisol metabolites. So this is a pretty normal level. So that tells you that the adrenal glands to some degree are firing and making cortisol, but that's all being rapidly metabolized. You can see these metabolism rates are very high, and so it's being metabolized very heavily to the cortisol metabolites. So that means you're making, you know, a decent amount of cortisol, but not enough to keep up with the body's needs, and so the total amount of free cortisol is low. So particularly if a person like this is under stress, you can see that their adrenal gland is not keeping up, potentially because of a lack of production and also because of hypermetabolism. So that's going to change a little bit the picture in terms of how we treat this patient. And you might look at someone like this and say you're, you know, moderately progressed in terms of if you want to call it adrenal fatigue or adrenal insufficiency. You know, here's a patient who, again, their adrenal glands are still firing a reasonable amount and making cortisol, but you're still pretty deficient in terms of how much you've got available to your body. So we're going to want to support, you know, the adrenal gland in a patient like this. And you can see in terms of the inactive form, which is cortisone, versus cortisol, that the overall preference for this patient is cortisol. So there's not really an issue there in terms of inactivating it to cortisone. The issue is probably 1, not quite making enough, and then 2, and just as significant and maybe more so, is more of a hypermetabolism of that that cortisol that's made. So, you know, you can look at some things like licorice root extract can help to stop that metabolism a little bit. Here's a person who actually, and this is where you want to take the whole picture into consideration, they actually said, hey, I have hypertension on their requisition form. So giving someone licorice root when they have hypertension is probably not a good idea. So you're going to want to really think your way through a case like this in terms of how you go about supporting the adrenal gland, potentially with glandulars or some herbal adaptogenic type things. And of course, you'd want to take into consideration, you know, their clinical picture in terms of fatigue. The fatigue for this particular patient was noted as mild. So again, you want to take all of that into consideration. Their symptoms were more related to the sex hormones, and so that might be more of a focus here, but we'd also like to get this adrenal gland supported so that we've got sufficient levels of cortisol, because again, these levels of cortisol are pretty severely low. So that's I think going to make it a wrap for this patient. So pretty interesting case, and we look forward to discussing more with you.